بسم الله الرحمن الرحيم. Assalamu alaikum. Good evening for all. I hope you have a very good weekend. I'd like to thank Novartis company for allowing us to give these lectures for the attendees and to spread information for everyone. And also I would like to thank Dr. Omar Rafai because he is the one behind this work today and he is arranging the whole program for this night. So today our talk is about distal radial fracture and my talk is about decision making. Sometimes we meet patients like this with a not accepted radiological appearance of the distal radius. However, the patient can perform all the activities of daily living and he's a very hard worker and he's very satisfied about the result in such a way. And sometimes you choose the operative option for the patient, but in spite you did not address some problems like the DRUJ subluxation. So you got a radiological alignment of the distal radius. However, the patient is complaining from pain and instability and weakness. So this how comes the dilemma to choose between surgery and conservative. So this is our agenda today. To start with introduction. As Dr. Omar said, this is a complex problem, not a simple one to deal with, and it requires a comprehensive approach integrating clinical evidence with individual patient needs and also the surgeon expertise. So this presentation will explore the multifaceted factors influencing optimal treatment decision. So the widespread impact of distal radius, number one is high incidence, like stated by Dr. Omar, is over 15% of all fracture, and this counts for more than 600,000 cases annually in US. And the bimodal distribution, it is observed in younger age group due to high energy trauma, and on the contrary, in the elderly of low energy fragility fracture, this linked to osteoporosis. So the third impact factor also the non-set decision, because the wide variability in fracture pattern, this makes different situations or different decisions can be taken for the same patient. So our goals for treatment of distal radius fracture is to preserve hand and wrist function. This is important to length and alignment and rotation of the distal radius, and this means articular congruency and the DRUJ alignment, achieve complete bone healing, early active finger and elbow range of motion. What are the options? The options is to do casting in the conservative management, to use an external fixator, to use a percutaneous spinning, or to use internal fixation, starting from the dorsal volar plating, combined dorsal and volar plating, dorsal bridge plating, and focal, which is fracture-specific internal fixation. What are the indications for conservation? The low energy fracture, low demand patient, medical comorbidities, minimal displacement with acceptable alignment. So you should match your treatment to the demands of your patient. And what are the indications for surgery? The high energy with instability, open fracture, radial shortening more than 3 millimeter, articular step off or gap more than 2 millimeter, dorsal angulation more than 10 degrees, DRUJ incongruity, and carpal malalignment. And these are the indication for conservation and operative management according to the American Academy of Orthopedic Surgeons. So what about the classification? We'll not talk about details in classification like Dr. Omar stated, but the classification of distal radius collectively is classified according to the intra-articular involvement, the degree of comminution, either dorsal or volar, and the situation or the involvement of the DRUJ. So the treatment is affected by classification in addition to, or you can decide according to these classifications, the type of injury, severity evaluation, the severity of trauma, the patient discussion and what he needs and what is his job, and the surgical options according to the experience of the surgeon and what is the prognosis. So this is a summary of the classification system since 1951. And I see the common classification system used nowadays is the Weber, which is AO, and it's comprehensive but complex. The Freakman based on joint involvement and the styloid involvement. Meloni divides intra-articular fracture into 4 types based on displacement. Fernandez based on mechanism of injury only. So the most commonly and widely used is the AO, which classifies the fracture into type A, which is extra-articular. Type B is a partial articular. Type C is a complete articular. And there is another more recently applied classification, which is called ideal. So this denotes the I is for joint incongruity, the D is for displacement, the E is for the energy applied for this trauma, the A for the age, and L for associated lesions. So according to the presence or absence of these categories, you can have a judgment or a rough estimation about the option you use for such patient, either conservatively or surgical. Outside these classifications, there are some eponyms for the distal fracture radius, which is not present in all classifications. So the D punch, which is the depressed fracture of the lunate fossa in the articular distal radius. The Barton is the fracture dislocation of radial carpal joint involving volar or dorsal lip. Chauffeur denotes radial styloid fracture. Cool is low energy, dorsal displaced, and on the contrary of Cool is Smith, low energy and volarly displaced. What about the instability? So there are some predictors about the instability, like is published in this paper, and it depends on the assessment of fracture. You can use the LaFontaine criteria stated by Dr. Omar before, and we got some indicators of instability like the patient age, because the younger the age, the more instability you can have if you use conservative management, the metaphyseal comminution, the shortening, which will lead to ulnar variance. So consider patient level of function and medical comorbidities. These are the LaFontaine criteria. So on the contrary of the previous slide for the indication of surgery stated by the American Academy of Orthopedic Surgeons, you will find some changes in these numbers. For example, the dorsal angulation now is 20 degrees, dorsal comminution more than 50%, either palmar or intra-articular, initial displacement more than 1 centimeter, radial shortening more than 5 millimeter, associated ulnar fracture, and severe osteoporosis. These are the LaFontaine criteria to decide to do surgery or to do conservative management for such patients. What are the guidelines? So I chose this American Academy of Orthopedic Surgeon guidelines. This is the most recently and most simple one to use. So if you use this short link for this criteria calculator, you can see this is the page will open according to the ortho guidelines. So you can tick the type of the fracture, like it is type A or B or C, and choose the mechanism of energy, either high or low, activity level of the patient, either normal, high functional demand, independent or homebound, and patient health according to the American anesthesia categories, and the other comorbidities or other injuries of the distal radius, like median nerve injury or open fracture, and so on. So we will take one example, and this is on the opposite page, opposite side of the page. You will find the answers when you choose these types. So for example, for our patient, we chosen to be a type C, and it is a low energy fracture, and it is high functional demand, and it's type 1 to 3 in the patient health, and there is no other injuries rather than the distal radius. So what will be the answers? So you get the answers in a green like this, spanning external fixation, and this will take 7 degrees or 7 points, volar locked plate 9, fragment specific fixation 9. So the more number you get, This means the more indication to use such type of management. And you will get some answers in the yellow. That means it is equivocal, like percutaneous spinning 6, non-spanning X6, 4, distraction plate 6, and dorsal plate is 6. And you will get some answers in red like this. That means you could not choose these types of management because of the poor prognosis, and it does not go well with your patient selection. So immobilization without reduction equal 1, reduction and embolization 3, intramedullary nail is 2. So according to this patient, you have the option to choose and discuss with your patient these 3 types of or 3 lines of management and to choose the best one you have experience in. And at last, you can email these results or print it or copy so to discuss it with your patient. So how to apply these principles? For example, when we put this, we have 2 scenarios of 2 distinct patients to illustrate how the discussed decision-making principles are applied. For example, this patient is old, like you see, so is elderly with low energy fall, and they have got extra-articular distal radial fracture. So the decision is a shared decision with the patient to use prioritizing non-surgical approach. The treatment is casting with close follow-up, emphasizing functional recovery over anatomical perfection in the X-ray. The other scenario in a young patient, so the profile of this patient is a young high energy trauma intra-articular fracture. So the decision is surgical fixation recommended due to joint involvement, and the treatment open reduction and the internal fixation to restore joint congruity and maximize long-term functional for high demands. And from these 2 simple scenarios, you can see that the clinical judgment by the surgeon should be shared with the patient according to the age and level of activity and the type of trauma he got. What about the evidence-based medicine? I tried to review a lot of articles regarding the distal radial fracture, either to operate or to conserve. So these are some examples, and you can notice that all of them will make the category of patients 65 years old and more. So this review of literature comparison between surgical and conservative and have been published in 2019. And in conclusion, they stated that it remains unclear whether using ORIF with plate and screw rather than conservative have any advantage. Another review article, comparison of conservative and operative treatment of the distal radius. Also, the age group is 65 years old and more. And this was a meta-analysis randomized control trials and included more than 500 patients. And it included 7 qualified studies. And the conclusion, surgical more effective radiographic only outcome, but not function. So no significant difference in functional outcome and the complication rate between surgery and conservative management of distal radius. Another comparison between surgical and conservative therapy, this is not a review, this is a prospective randomized controlled trial, and it included 80 patients. All of them also are 65 years old and more. And as in conclusion, surgical treatment proved to be superior to conservative management, but satisfaction was significantly better in the surgical group. Another meta-analysis and review of literature published in 2024 regarding surgical versus conservative in the elderly, also 65 years old and more, and included 2,400 patients. And in conclusion, they stated that surgical treatment offers slight functional advances in grip strength and dash score, but is associated with higher pain due to the complication of plate and screw, as stated by Dr. Omar and will be illustrated by Professor Tariq later on. So the conservative treatment remains viable with minimal difference in long-term follow-up for the wrist function between surgery and conservative. Another meta-analysis published in 2024, and this patients also 65 years old and more. It included 17 papers, and it included 1,730 patients, and it showed that surgical treatment improves the grip strength, decreased dash score, and improved pronation and supination. So in general, low energy fractures have less potential for instability. So no improved long-term outcome with surgery compared to non-operative, as stated by the American Academy guidelines, as we have said. And sometimes you are faced with a deformity like the X-ray we have seen in the first talk of my presentation, but there is existing evidence concerning wrist deformity following treatment of distal radius fracture suggested that this deformity is common, even if you used internal fixation. And most of this deformity are not troublesome or bother the patient. And this was published in these years, 2020, 2005, 2005, 2011, 2000, 2009, all stated the same state that deformity of distal radial fracture, whether type of treatment used, is not bothering the patient, and he can cope with in daily activities without problem. At last, the conclusion. There are many options for treatment of distal radius fracture, as we have seen, but patient factors must be included when considering treatment options. The ortho guidelines is continuously evolving, like we have seen, and this is very simple, and I advise you to practice it because it will simplify the way of thinking and the judgment, so you can decide with your patient the proper way of treatment for each patient. Most elderly patients do well with non-surgical treatment, and surgery, which is like plating, for example, is considered for unstable, displaced, or intra-articular fracture, active, healthy, either elderly or young age, which need better wrist function. And I finalize my talk with this example. She's a close relative to me. She fell down while trying to catch a train, and she got bilateral distal radial fracture. And you can see, or you can notice the way of displacement. But this is a close-up X-ray. She, with the surgeon, decided to do conservative management in bilateral below elbow plaster cast, and this is the final outcome. As you can see, the lens is restored, the DRUJ is stable, and the range of motion and the functional outcome was perfect in spite of having bilateral distal radial fracture. Thank you very much for your attention.